Moving on to the next topic, I would like to call upon the chairperson, Dr. Raghunandan, who's the GC member, RSCAP, and Director for External Health Services, Sri Madhusudan Sai Medical Center and Research, Bangalore, Tumkur. Over to you, Doctor.
Good morning, everyone. Today, the next topic is diabetes and CKD, Nephro perspective. I would request Dr. Mritunjay Kumar Singh, our honored speaker. Sir is a consultant physician and nephrologist, Gaya JE, founder member of CCDSI, executive secretary of CCDSI, vice chairman, API Bihar chapter. Over to you, sir.
Respected Chairperson, sir, actually I have lost my pen drive yesterday evening, so I am trying some other slide. My topic is diabetic mellitus and CKD on nephrology perspective. So you all know that diabetic and CKD is double whammy, and if you will, okay, so if you will see the data from the global burden disease, you will find that from 1991 to 2023, there is a huge increase in this CKD and type 2 diabetes mellitus. And the reason is that our population is aging and the metabolic diseases is increasing, and the amount or the healthcare professional needed to tackle these diseases is lacking. And this disease is mostly occurring in the elder population, and so the problem is very huge, and it is taking a lot on our healthcare system. So with this, I will start my topic. You all know that CKD has a significant impact on the patient with type 2 diabetes, and it has a huge burden on the healthcare professionals. So kidney disease increases mortality in type 2 diabetes. You can see here, if the patient is having kidney disease, the total and cardiovascular mortality is high. But if it is associated with this diabetes, then the mortality rate is increased to many-fold in the range of 31.1 to 19.6. Now, there is a spectrum of diabetic kidney disease. If you know the chronology of diabetes mellitus, then initially it is the hyperglycemia which takes the lead, and it causes microvascular complications, and the patient in this is younger patients, and the disease occurring in this part is the retinopathy, nephropathy, and proteinuria is in the great extent. But as the disease progresses, the patient gets older, the vascular disease takes the lead, and there is a classical ischemic heart disease risk factor increases, and there is a little proteinuria. So whenever we are dealing with diabetic and CKD, we should always suspect non-proteinuric diabetic kidney disease, because these patients are in chunk. In the 50% of these patients are having non-proteinuric diabetic kidney disease. And the thing is that the most of the trial have included proteinuric diabetic kidney disease. So we don't know the exact what we should do in this non-proteinuric diabetic kidney disease. Now, what is CKD? CKD is defined by kidney damage and abnormalities in kidney structure and functions which last for more than 3 months. Kidney damage, any autosomal polycystic kidney disease or any hydronephrosis which lasts for more than 3 months, or proteinuria or hematuria or active urinary sediments. If it lasts for more than 3 months, we say that this patient is suffering from CKD, and by EGFR classification, the EGFR should be less than 60 for more than 3 months. So what are the risk factors for CKD development and progression? It is diabetes, well known, high or very high albuminuria, family history of hypertension, especially if poorly controlled, target blood pressure for patient with type 2 diabetes with kidney damage is less than 130/80, recurrent acute kidney injury also leads to this CKD, cardiovascular disease, dyslipidemia, obesity, smoking, structural renal tract disease, recurrent renal calculi, prostatic hypertrophy, multi-system disease with potential kidney involvement, family history of hypertension, end-stage kidney disease, or hereditary kidney disease. So assessment of both albuminuria and eGFR is required for early CKD diagnosis, because maybe in the initial phase you will only got the albuminuria, but you should always do these two tests simultaneously in a patient to screen the CKD. And GFR in healthy patient compared with patient with type 2 diabetes and normal albuminuria, you can see here that as the GFR decreases and proteinuria increases, the GFR decline is more. GFR decline more. You can see here that nephrotic proteinuria, GFR decline is many more fold high. Now you can see here that increasing albuminuria is associated with higher CV mortality risk across all eGFR categories. Even if albuminuria is less than 15 and eGFR is high, this proteinuria is also significant for these kidney patients. Now, what the international guidelines recommend screening at least annually for kidney function in patients with diabetes. ADA, KDIGO, and these ESC guidelines recommend screening for kidney dysfunction by laboratory evaluation, and these laboratory evaluations should include urinary albumin-creatinine ratio and eGFR. While examining the urinary albumin-creatinine ratio, you should always suspect that there is a transient proteinuria in some patients. So it should be repeated if there is a suspicion of transient proteinuria, as in the cases of high fever, if patient is having, patient has gone for any treadmill, or patient has this UTI, then you should always do this urinary albumin-creatinine ratio 1 week later, and then you should consider this as a valid test. Now, this is the characteristic and morphological changes which occur in the glomeruli in diabetic kidney disease. You can see here that in the left side, there is a healthy individual with patient with diabetic kidney disease. There is an arterial hyalinosis, there is a basement membrane thickening, mesangial cell hypertrophy, collagen deposition, podocyte loss, hypertrophy, podocyte food process effacement, albuminuria, tubular epithelial atrophy, activated myofibroblasts and matrix are increased, and influx of inflammatory capillary rarification is there. This is the same thing. Now, what are the signs and symptoms of diabetic kidney disease? Those signs are albumin or protein in urine, hypertension, early hypertension is there, high urea nitrogen and creatinine levels in blood, and anemia occurs late. While the symptoms are weight gain, ankle swelling, increased nocturia, nausea, vomiting, loss of appetite, weakness, increasing fatigue, itching, muscle cramps, particularly in legs. So these are the 5 stages which has been defined for the progression of diabetic kidney disease. In the stage 1, there is an early functional phase with reversible glomerular hyperfiltration. So in this phase, you may not get anything. Urinary albumin-creatinine ratio is normal. eGFR is quite high in the range of 120 to 150. But later on, when there is a pseudo-normalization of eGFR and proteinuria started appearing, then we can detect the disease. That's why there is a lot of rumbling occurring in the nephrology society that we don't have the early marker of diabetic kidney disease or CKD, and that's why there are several inflammatory markers, mitochondrial markers are in the pipeline for early diagnosis of these diseases. Still, we have to rely on this urinary albumin-creatinine ratio and eGFR. So, by albumin-creatinine ratio and eGFR, we have this picture, and here we can have risk stratification of the patient. You can see here that there is a yellow zone where there is a patient in the low risk. But in the yellow zone, say if patient is having eGFR 64 or 65, then he is having in the green zone. But if albuminuria is more than 300, then he goes into the high risk. So albuminuria is very important and targeted. That's why most of the trial have targeted the albuminuria. But mind this, that non-proteinuric diabetic kidney disease is also there. So staging is based on the eGFR and albuminuria. A more severe stage and a more severe albuminuria is closely linked with worse outcome and progression of CKD. Now the key feature, because I am repeatedly telling about the non-proteinuric renal disease, the key feature is high prevalence in women with metabolic syndrome. Declining eGFR can be recorded before or without progression to macroalbuminuria. Decreased renal function without concomitant proteinuria is reported in about 50% patients with type 2 diabetes and renal disease. accelerated eGFR decline and the sequential increment in albuminuria can be viewed as a two different pathways that might not cover the same patient. Uncertain benefit from ACE inhibitor and ARB in these patients. Now, what are the impact or risk factor for disease progression? You can see here that proteinuria has the most important factor, and then other are glycosylated hemoglobin, systolic BP, serum uric acid, and vascular comorbidities. So the aim of the treatment, ADA recommend that in people with chronic kidney disease who have more than 300 mg per gram of urinary albumin, a reduction of 30% or greater in urinary albumin is recommended to slow chronic kidney disease progression. And we have, with diabetes, we have microvascular complication and macrovascular complication. I have already told you about this because there is a spectrum of disease occurring in the diabetic kidney disease. These are the trials. Before 2015, we have very few drugs in our armamentarium to treat the diabetic kidney disease or CKD related to the type 2 diabetes. But after 2015, we have 3 or 4 drugs, and there are several trials with CV outcome and kidney outcome, which have shown that this SGLT2 inhibitor, this GLP-1 agonist, and this finderone, non-steroidal mineralocorticoid receptor antagonist, is beneficial in retarding the progression of cardiovascular disease and CKD as well. So we will see these in the next slides. So what is the updated guideline by the KDIGO? KDIGO says that an ACE inhibitor or ARB is recommended in patients with diabetes, hypertension, and albuminuria, and titrated to the highest approved dose that is tolerated. Highest approved dose when patient is not having this hypotension or other things, patient don't become symptomatic, till we should increase the dose of ACE inhibitor and ARB. And SGLT2 inhibitors should be given to all patients if eGFR is more than 20, but now the recommendations are changing, and you can continue with this SGLT2 inhibitor till patient is on dialysis. A non-steroidal MRA with proven kidney and CV benefit is suggested in patient with type 2 diabetic, eGFR more than 25, with normal serum potassium. To start the finderone or this newer molecule, your patient potassium should be less than 4.8. Anti-hyperglycemic therapy in patient with type 2 diabetes and CKD. Metformin should be considered in patient with type 2 diabetes, CKD, and eGFR is more than 30. With less than 30, we should be little cautious. We should monitor this. We should monitor for this acidosis, and we should also give this patient vitamin B12 injection because this vitamin B12 deficiency is there. So if you will see the hierarchy intervention, in the base there is a diet, exercise, smoking cessation, weight, lifestyle modification is the most important thing which we should advise our patient. Then these drugs are metformin, SGLT2 inhibitor, RAS inhibitor, then GLP-1, this non-steroidal MRA, antiplatelet, lipid management, glycemic management, and blood pressure control is other things. So this is in the nutshell. Lifestyle modification is the treatment which we should give to all patients. First line therapy as far as type 2 diabetes is concerned, SGLT2 inhibitor and metformin is there. For all patients, we should add RAS inhibitor in the maximum tolerated dose, and moderate or high intensity statins should be given to all patients, whether it is type 1 diabetes or type 2 diabetes. And then regular measurement of glycemia, albuminuria, BP, CV risk, and lipids should be done. Additional risk-based therapy should be done. If glycemia is not controlled, then we should add this GLP-1 receptor agonist, non-steroidal MRA if given, if ACR is more than 30 and normal potassium. This steroidal MRA should be given to treat resistant hypertension, while this non-steroidal MRA should be given to this proteinuric patient to retard the inflammation and fibrosis. Now, this is the ADA guideline which said that if patient is having more than 160 to 100 BP, then we should start with dual agent ACE inhibitor and CCB simultaneously. If BP is between 140 to 160 and 90 to 100, we should start with one molecule ACE inhibitor or ARB. And then we should titrate the dose in every 1 month, and we should keep the target below 130/80. While hyperglycemia is concerned, we should start with metformin and SGLT2 inhibitor, and we can add a GLP-1 agonist if patient is having atherosclerotic cardiovascular disease. Then we should titrate the dose of this molecule, And additional drugs we should use as insulin, sulfonylurea, and DPP-4 inhibitor. Now, this is the ADA recommendation which I have already told you. Metformin should be given if the eGFR is more than 30. If patient is having albuminuria, we should go to maximum tolerated dose of ACE inhibitor ARB, then finerenone should be added. With type 2 diabetes with established heart failure with preserved vessel fraction or reduced ejection fraction, SGLT2 inhibitors should be given. Type 2 diabetes with established atherosclerotic cardiovascular disease, SGLT2 inhibitor or GLP-1 receptor agonist should be given. Now, RAS inhibitor are recommended by the ADA as a foundational treatment for patients with type 2 diabetes. However, a persistent risk for kidney disease progression exists. So, what are the protective effect of SGLT2 inhibitor? It acts by two methods. First is by this hemodynamic method, which is very important, most important. Here, what it does, it activates the tubuloglomerular feedback, and we all know that in diabetes and hypertension, there is a hypotonia in the arteriole, afferent arteriole, and that's why there is a gush of blood going to the capillaries of this glomerulus and causing proteinuria and damage. So, if you have to maintain the tone of this afferent arteriole, then we should give this patient SGLT2 inhibitor, and then other effect is this metabolic effect by glycosuria, decreases HbA1c, and weight loss. Now, these are the three trials, Gradence, DAPA-CKD, and IMPA-KIDNEY. All have proven benefit for the kidney patients. DAPA-CKD and IMPA had also involved non-diabetic kidney patients. So, it is very important that in non-diabetic kidney patients, these molecules are also proven benefit. Despite RAS blockade and SGLT2 inhibitor, patients with type 2 diabetes and advanced CKD are at risk for CKD progression. And because we are targeting with these two molecules, we are targeting only the hemodynamic and inflammatory pathway, but we are not targeting this inflammation and fibrosis, which occurs through this MR overactivation. And finerenone is one molecule which targets this, and it can decrease the kidney damage, vascular damage, and heart damage. So, how this finerenone is different from this aldosterone antagonist? Because finerenone is bulky non-steroidal MRA. It has highly potent and highly selective to this mineralocorticoid receptor. It has very less T-half, and that's why side effects are very less. If you will compare with placebo, it has very minimal hyperkalemia. So it is the drug for the CKD associated with type 2 diabetes, while this spironolactone should be the drug for the resistant hypertension or congestive heart failure. Now, these are one is the Fidelity trial. Fidelity trial, which has combined both Figaro and this Figaro. We are moving ahead. Okay. This Fidelo DKD. So, Fidelity trial is actually pooled trial, and it has shown that these non-steroidal MRA are quite benefit. Another trial has come recently, which is not mentioned here because this is the old slide. I have lost my pen drive, that's why that is not added. One trial is confidence trial, which has recently came, and that says that we should start SGLT2 inhibitor and mineralocorticoid receptor antagonist simultaneously in a patient if patient is on the maximally tolerated dose of ACE inhibitor or ARB. So this is very important, and this is all covered in the guidelines. I have already told you that finerenone should no effect on HbA1c, modest effect on systolic BP, and no imbalance in sexual side effect. Overall, adverse effects were very similar between the groups. So when we will start, if potassium is less than 4.8, start with 10 mg daily. If eGFR is between 25 to 59, start with 20 mg daily. If eGFR is more than 60, monitor potassium at 1 month after initiation, then every 4 months. Increase dose to 20 mg daily if on 10 mg daily, if patient is on 10 mg daily. Restart 10 mg if previously held for hyperkalemia and potassium is now less than 5. So in any case, if patient potassium is permitting, we should add this molecule in proteinuric diabetic kidney disease. So we can see here the progressive delay in kidney failure with various treatment options. So first you can see that BP control, there is a little risk reduction, but if we will add RAS inhibitor, there is a more reduction. If we will add this SGLT2 inhibitor and MRA, there is a huge reduction in the risk, and patient is benefited more, and he will have dialysis-free life for the more years. So there are some non-pharmacological intervention for CKD in patient living with type 2 diabetes. While diet is concerned, generally eat a healthy diet, maintain daily protein intake of 0.8 per kilogram of body weight, limit salt intake to less than 2 gram, engage in moderate to intense physical activity at least 150 minutes per week, avoid sedentary behavior. Patient who use tobacco should stop smoking or using tobacco. So the main goal is prevention of cardiorenal risk, and there are 4 pillars for this: glycemic management, blood pressure management, lipid management, agents with CV, and kidney benefit as indicated. And pillars of therapy are this RAS blockade, SGLT2 inhibitor, this non-steroidal MRA, and GLP-1 receptor agonist. With this, I conclude my talk. Thank you very much.
Thank you, sir. Thank you. Any questions? We can take one question.
I think there are a couple of points when we are managing CKD. Firstly, if you look at the hazard ratio for cardiovascular mortality or CV mortality, even it is 1.77 even when it is in the normal range of 0 to 30. Secondly, all these 4 therapies provide incremental benefit on top of each other. Thirdly, step care approach just has gone off in heart failure. All these drugs, at least 2 or 3, may be started right from early age, particularly if the patient is in advance, because they provide incremental benefit. And if you have a problem of hyperkalemia, SGLT2 inhibitors and GLP-1 RA, particularly with obese, have liver involvement. And for non-proteinuric, although there's no data, but the drugs should be used because they continue to provide other benefits besides CKD, cardiovascular benefits others. Doesn't mean if you have non-proteinuric data, they should not be used.
Just a comment here. The most recent is the results, promising results from the FIND CKD trial, where the non-steroidal MRAs have shown benefit in reducing albuminuria and arresting the decline of EGFR in non-diabetic kidney disease. That's a very good finding that we have got.
Thank you, sir. Thank you for your feedback.
Thank you so much, doctors. Thank you to the speaker and chairperson. We request you to move to the selfie area, which is outside the hall.